We started drilling.
Good morning, everyone, and welcome to this morning's webinar. Planned for today, we have a debate with the topic being cytoreductive nephrectomy in the era of immunotherapy. Is it still justified? Today, we have two excellent speakers from Stellenbosch and from Groote. We have Dr. Bernard Marais, who will be arguing for cytoreductive nephrectomy. He will be presenting the case as to why cytoreductive surgery still has a role in the modern era. And then arguing against this motion, we have Dr. Matiba, who's from Groote, and she will be presenting the case against routine use of cytoreductive nephrectomy in the setting of immunotherapy. Dr. Marais, I see you have your slides shared already. You can begin with your talk. Thank you.
Thank you, Aman. Thanks, everyone. I'm Bernard, as Aman said, and I will try my best to argue for the case of cytoreductive nephrectomy. If the audio gives an issue, just please let me know. My earphones are a little bit wonky. So yeah, so we know that renal cell carcinoma is the 14th most common cancer globally. Just over 400,000 cases diagnosed in 2022, 155,000 deaths. And we know about a third of them, some sources say 15%, will be diagnosed with synchronous metastatic disease. Patients initially diagnosed with localized disease, about 20 to 40% of them will eventually develop metastases. And it's really a fatal disease with really poor 10-year survival rates. Because the ever-evolving and the rapidly evolving field of systemic therapy in the metastatic disease, the role of the cytoreductive nephrectomy is quite fluid. So the rationale traditionally behind the cytoreductive nephrectomy is that to reduce the tumor burden, to improve symptoms, specifically local symptoms, and then to potentially enhance the effectiveness of systemic therapies. And I just want to reiterate here and make it quite clear that, yes, we are arguing for the cytoreductive nephrectomy in the immunotherapy still justified, yes, but very importantly, in combination with systemic therapy. Yes, here and there'll be things that's maybe not, but in most of the cases, we are arguing that it has a role, but in combination with systemic therapy. The guideline slide I almost always have at the end of my talks, but I thought I'd throw it in here in the beginning to kind of solidify and show that it is still justified. This is a 2026 guidelines, and if the experts justify using it, why should we not? So there's a couple of scenarios that is mentioned, albeit a weak recommendation. We can discuss a cytoreductive nephrectomy in patients, or a delayed nephrectomy in patients who might have a benefit from systemic therapy first. We could potentially perform an immediate nephrectomy in patients with a good performance status who don't require immediate systemic therapy. And then in the setting of a oligometastatic disease, where there can be complete local control of the metastases. So we're going to look at it from two very simple points. Basically, one is the biological rationale, and then secondly, we are going to delve and tear apart quite a lot of evidence for the efficacy thereof in various situations that I just mentioned. Essentially, in a palliative role, consolidative or delayed cytoreductive nephrectomy. We'll touch upon a possible upfront cytoreductive nephrectomy and the role of it in oligometastatic disease. Now, we can't talk about cytoreductive nephrectomy without touching on the phenomenon of spontaneous regression. Now, that was seen that metastases essentially melts away after the primary tumor has been removed. And while it's an important phenomenon to know about, it is very rare, and I think it's quoted to be around about 1%. The earliest case report I could find was in 1982, and the most recent was in 2020. This also kind of points towards the fact that the renal cell carcinoma isn't just a clump of cells that causes local compressive issues. It's a highly immunologically active tumor, and the primary tumor elicits a whole bunch of effects that essentially renders the immune system sort of lagging and slow, and it suppresses it essentially. So the primary tumor essentially there's continuous antigen exposure that leads to overstimulation and possible immune tolerance. It produces a whole lot of immunosuppressive cytokines. And all of that can lead to T cell exhaustion that essentially causes a slow and sluggish immune response to this foreign tumor antigens. Also important to note is the PD-L1 ligand that's expressed by the tumor cells that essentially increases the activation and the binding to the CLTA4 and the PD-1 ligands on the T cells that essentially causes T cell exhaustion, as I said, as well as defective granzyme B expression, which is basically inhibits the cytotoxic activity of the T cell. So the rationale behind, the immunological rationale behind the cytoreductive nephrectomy is essentially this immunologically active tumor that causes immunosuppression and basically puts the brake pedal on the T cells. Once you remove it, it's essentially a big immunologic sink that gets removed. The T cells wakes up, and the immune checkpoint inhibitors can then activate and sort of put the T cells in overdrive to go after the metastatic deposits or the metastases. Obviously, it's not as simple as I just explained it, but that is it sort of in a nutshell. To touch on the cytoreductive nephrectomy, we're going to go. It's a little bit of a trip down almost in memory lane. It's more like history lane. But we are going to the rise essentially of the cytoreductive nephrectomy was because of two prospective randomized control trials in the early 2000s, the SWOG 8949 and the ERTC trial that essentially had a very similar, exact same design that randomized patients with metastatic renal cell carcinoma either to undergoing a primary cytoreductive nephrectomy and then undergoing systemic cytokine treatment versus a second arm that only received cytokine treatment, and they essentially look at the overall survival. Now, this is a combined analysis of those two trials that essentially found that patients undergoing a cytoreductive nephrectomy had a 6-month survival advantage compared to the drug arm alone, and this basically equated to a 30% risk reduction of death. And this cemented the cytoreductive nephrectomy as standard of care in those days. Sorry, there seems to be a slide that might have skipped, but anyway, researchers in the time though saw that there were some patients, certain patients did quite poorly. There were patients who never made it or never recovered well enough to even receive the systemic therapy, and certain patients who received systemic therapy that did poorly anyway. And the MSKCC prognostic model was essentially developed, looked at various factors and grouped patients either in good risk, good, intermediate, or poor risk groups. And I want to point out the poor risk group here because it's important going forward, where the median overall survival is really poor in the poor risk group. And it essentially concluded or whether the patient's treated with nephrectomy or systemic therapy in those days, the outcome was relatively poor either way. So then we entered the targeted therapy era, or the tyrosine kinase era, where cytoreductive nephrectomy kind of remained an important part of the management. This was based though on data from the cytokine era, and supported by mostly retrospective studies on the targeted therapies. And while the EIU updated its position, it acknowledged that the rate of cytoreductive nephrectomy was declining. It acknowledged there is still some role to be had, but high-level evidence was lacking. And then come the Carmina trial, or the fall of the cytoreductive nephrectomy. Now, this is a landmark study, a prospective randomized controlled trial that essentially randomized patients with clear cell RCC either to undergoing an upfront nephrectomy and then receiving systemic TKI or sunitinib, versus a drug-only arm that was only treated with sunitinib. And this was essentially a non-inferiority study looking at overall survival. And the primary endpoints here was important because researchers found that the sunitinib arm, the overall survival was 18.4 months, and in the surgery arm was 13.6, essentially concluding that sunitinib alone in these patients is not inferior, which had a significant impact on the rates of cytoreductive nephrectomy around the world. Now, this is just data from the USA. There's similar data from Europe, I think. But it shows a significant decline in cytoreductive nephrectomy after the publication of the Carmina study, or after the results came out. What's interesting, though, is that there were still studies that showed that patients treated with targeted therapy who underwent a cytoreductive nephrectomy still had there was still some survival advantage, although those were all observational studies. And this is systematic review from Bindi and colleagues showed that it was really just the Carmina trial that showed otherwise. Now, of course, that is a prospective high randomized trial, high level of evidence. But the urological community was asking the question, does the Carmina mean that we throw out the cytoreductive nephrectomy completely? And why do these other studies show that there is a survival benefit, and decided to have a bit of a closer look? Now, once we dissect the Carmina trial, there are quite a few discrepancies, quite a few issues that's quite important to note. So firstly, the study was underpowered. The aim was to enroll 576 patients that only reached 450 over 9 years, and the study was actually closed prematurely. And one critic mentions that it is a likelihood that patients were just unwilling to be randomized in the setting. The same critic also mentions that the outcome may have been different had the study been allowed to meet the accrual goal. That remains, that we will never know, I guess. Secondly, and very importantly, the Carmina trial only included, and this was not by design, this just happened, only had intermediate and poor risk patients according to the MSKCC group. Now, we know that patients in the poor risk MSKCC group typically do worse. They have patients with a high metastatic disease burden usually have they're less likely to benefit from a cytoreductive nephrectomy, and about 45% of this cohort was of the poor prognosis group. And more importantly, the surgery arm had more patients in the poor prognosis group than intermediate group. Investigators were also allowed at their discretion to exclude patients or low-risk patients that they felt might benefit from surgery. So they basically excluded patients that was probably the most important to study. And then thirdly, and probably because of the design and the cohort included in the study, there was significant crossover between groups. The surgery arm, about 25% of them did not receive the intended treatment. And then importantly, 17% of the drug-only arm eventually underwent a subsequent cytoreductive nephrectomy because of local symptoms. Now, I'm not. This is a little block from the trial, from the paper. And while I'm not saying this is the case, I think it's always important to have a look at the conflict of interest, especially in trials that examine novel, expensive drugs. Again, I'm not saying this was the case, but there's quite a lot of disclosed conflict of interest, a lot of consultation fees, a lot of honorariums that were paid by certain drug companies. And we should be aware of these things when we assess and scrutinize trials. If you are interested, this book by Ben Goldacre is a really good book that kind of highlights the effect of big pharma on our daily practice. So what can we really take away from the Carmina trial? Does it mean we chuck the cytoreductive nephrectomy out completely? No, what we can take away is that it shouldn't be a routine choice in high-risk patients. It shouldn't be a routine choice in patients with metastatic disease, as it was in the cytokine era. And it should definitely not be offered as first line to poor risk patients. However, it doesn't rule out the role of an nephrectomy in patients with low-risk disease because they weren't included, as well as those with oligometastatic disease. Interesting, if you look to that little table on the left, that was a post hoc analysis, or essentially a per protocol analysis that was done 3 or 4, or published about, I think, 3 years after the original publication, done by the same group. And after all the crossover chaos was removed and they looked at patients who actually followed the intended treatment arms, they found that patients in the intermediate risk group who only had one risk factor had a significant survival advantage in the surgery arm compared to those in the drug arm, which was not like that in the original analysis. This is also from the post hoc analysis, and I mentioned that 70% of patients in the drug only arm underwent a secondary nephrectomy because of symptoms. Now, interestingly enough, those patients had a significantly longer overall survival versus the patients who in the drug arm who did not undergo a subsequent nephrectomy, of 48 versus 15 months. Now, that brings the question not whether a cytoreductive nephrectomy should be done or not, but it's more for me, or what I take away from this, it's more the question of timing, about not if it should be done, about when it should be done in the setting. And the SIR-TIME trial, or the surgery time trial, it was the next landmark study who tried, or basically to answer that question. They randomized patients into either undergoing a primary cytoreductive nephrectomy followed by systemic therapy, that was sunitinib, versus first undergoing systemic therapy and then undergoing deferred or delayed cytoreductive nephrectomy. Now, their primary endpoint was progression-free survival, and the secondary endpoint was overall survival. And while they also had quite poor accrual, and the primary endpoint had no difference, the secondary endpoint, the overall survival, we see that patients who underwent deferred nephrectomy had a 32.4 months median overall survival versus 15 months in the immediate nephrectomy. Patients who went a deferred nephrectomy, also a larger percentage ended up receiving the systemic therapy. And then the authors also concluded that a cytoreductive nephrectomy is safe after systemic therapy, because that was also brought into question. So now we're in the immunotherapy era. We don't have randomized prospective high level of evidence trials that can give us the answer to this debate, essentially. Otherwise, we probably won't be having this debate. But so we are forced to look at the data that we have available to us, which is essentially observational and retrospective. One interesting study that kind of, I think, developed from this this post hoc analysis, finding that that indicated patients in the intermediate risk with only one risk factor might benefit from a cytoreductive nephrectomy. Remember, that was in an upfront setting. essentially then conducted a study looking at the survival, overall survival in patients who were treated with either immune checkpoint inhibitors or targeted therapy. And then they looked at the difference between those arms of the patients who did and who did not undergo a cytoreductive nephrectomy. Now, the vast majority were patients treated with targeted therapy, but there was about 437 patients treated with immune checkpoint inhibitors. Nonetheless, we found that there was a significant survival, or a significant difference in the median overall survival when you look at the patients receiving systemic therapy and a cytoreductive nephrectomy versus no cytoreductive nephrectomy in an upfront setting. Now, they find that the survival advantage was mostly in younger patients with fewer risk factors or IMDC risk factors, with no bone, brain, or liver mets, a better performance status, and concluded that this is possibly due to the immunomodulatory effect of the cytoreductive nephrectomy, essentially, as I mentioned, removing that immunologic sink. And they concluded that an upfront cytoreductive nephrectomy has a survival benefit in well-selected patients with in a metastatic renal cell carcinoma treated with either targeted therapy or immune checkpoint inhibitors. And that allows a much more individualized and selective approach to using this in these cases. They found that patients, as expected, with worse survival outcomes were patients with poor risk features and with a high metastatic burden. Singler and colleagues looked at survival rates in patients undergoing patients who were treated with immune checkpoint inhibitors who either did or did not undergo cytoreductive nephrectomy. This is a retrospective study of almost 400 patients and found a significant difference or significant overall survival benefit if a patient was treated with the immune checkpoint inhibitor and underwent a cytoreductive nephrectomy. Now, this included both upfront and deferred cytoreductive nephrectomy. And what's interesting here that we picked up from this data is that when you look at the percentage of negative surgical margins, median post-operative length of stay, as well as the 30-day post-operative readmission rate, they are all the same between patients undergoing either primary or deferred cytoreductive nephrectomy. Now, that could potentially speak about the feasibility of and safety of doing it in both settings. And what I found quite impressive is the fact that there was no readmission rates in the deferred arm, where one could expect a local reaction after systemic therapy, possibly making the operation slightly harder. This study from Britton and colleagues also looked at the role or the overall survival in patients undergoing a deferred cytoreductive nephrectomy in various settings. This is a systematic review and meta-analysis. And if you just look at that forest plot on the top, so firstly, they included 19 studies. This included both the CERTIME and the Carmina study, but it also included studies from the immunotherapy era. And if you look at that forest plot, when overall survival was compared between patients undergoing a deferred versus an upfront nephrectomy, there was a significant advantage for those who underwent a deferred cytoreductive nephrectomy. And that advantage was even more pronounced when a deferred cytoreductive nephrectomy was compared to patients who only received systemic therapy. I mentioned the case of oligometastatic disease. There is no clear definition of what oligometastatic disease is in the setting of metastatic renal cell carcinoma, but it's generally regarded as between 1 and 5 lesions. We know that the more lesions, the worse the prognosis. And from the Carmina trial, patients with a single metastatic site in the surgery arm had a significantly better survival than patients with 2 or more sites. So we know that the survival benefit is lost with the more metastatic sites a patient has, as well as the the clinical stage seems to also have a role. Lung metastases seem to do better than liver, brain, and bone metastases. And the cytoreductive nephrectomy in oligometastatic disease really comes to the fore in a case, or in cases where a patient has a low IMDC risk with a small metastatic burden who is asymptomatic, and who undergoes a concurrent metastasectomy or metastatic directed therapy. And this might actually lead to delaying systemic therapy. That might be both advantageous to in terms of side effects as well as cost. I mentioned palliative nephrectomy as a role. Now, this is a study that looked at 317 patients with metastatic renal cell carcinoma who presented and how they presented, and a significant proportion presented with symptoms, about 2/3, and a third of patients presented with local symptoms, either that of hematuria, flank pain, abdominal pain, or a mass. And then the investigators looked at the effect of a cytoreductive nephrectomy on those symptoms. Now, at the top on the right, while the effect on any symptom is important, it showed an improvement in any symptom of about 71% and a resolution in 43%. The big advantage is really in local symptoms, where one can see there's a complete resolution in local symptoms in 91% of cases, and an improvement in 95% of cases. So an excellent control of terrible local symptoms. And we concluded, as I mentioned, a large proportion of patients with metastatic renal cell carcinoma are symptomatic at diagnosis, and a cytoreductive nephrectomy has a positive impact on the symptomatic status. Now, a debate wouldn't be a debate if I took a shot or two at the data that drives the immune checkpoint inhibitors. This is essentially an analysis of important landmark trials that cemented the benefit and the superiority of immune checkpoint inhibitors over the conventional TKIs or sunitinib in this case. And what's important is that the complete response rate in these trials was significantly higher than any of the other systemic therapies before. But when one looks closer, between 70 and 80% of these patients were nephrectomized, essentially. So this is essentially patients who underwent, this data is essentially data that looked at patients who that had a cytoreductive nephrectomy at some stage. And this causes obviously a couple of issues. This possibly means that patients enroll in these studies, the nephrectomies, were probably healthier patients with a better performance status, and this might just overestimate the efficacy of the immune checkpoint inhibitors, especially in cases where it's used with the primary tumor still in situ. Then tumors were debulked prior to start, or many of the tumors were debulked prior to starting the immune checkpoint inhibitors. And that really raises the question whether the advantage seen is because of the effect of the immunotherapy or because of the prior nephrectomy being done. And of course, the question is raised whether these results can probably not be extrapolated or used in patients with the primary tumor still in situ. So, just to finish off and to kind of conclude, why do I think the cytoreductive nephrectomy is still justified? We spoke briefly about the immunological evidence, essentially removing the immunological sink that then helps the T cells and kind of gives the immune checkpoint inhibitors something to work with. We looked at the evidence for the efficacy in various settings. We just spoke about the palliative cytoreductive nephrectomy providing excellent symptom control. a survival advantage in a well-selected patient in the setting of a consolidated or a delayed cytoreductive nephrectomy, especially after they respond well, or mostly if they respond well to systemic therapy. We touched on patients with low-risk disease who's fit and healthy, who might benefit from an upfront cytoreductive nephrectomy. And we mentioned that oligometastatic disease, the cytoreductive nephrectomy with a metastasectomy or metastatic directed treatment might delay systemic therapy, and that might have an advantage in terms of systemic side effects as well as cost. Now, where are we now is the next question. So in my mind, this is essentially where we are. We are in the pre-game analysis of a very exciting game, essentially, and my apologies for the rugby analogy, because there are three very exciting randomized prospective high-level evidence control trials in the pipeline. As far as I understand, the Nordic Sun was already supposed to be completed by 2025, and the probe and the Cyto kit would complete in the next few years. And this would hopefully help us answer or more sort of conclusively answer the role of the cytoreductive nephrectomy in the setting, and we might not have to debate it at least until the next round of drugs come along. So why, just something else to think about. If you put yourself in a patient's shoes and you are young and fit, I assume most of the audience is, would you rather choose a pill or maybe a IV therapy every 21 days? And would you feel comfortable leaving a large primary tumor inside of you? I just again reiterate that the evidence against cytoreductive nephrectomy, most notably the Carmina trial, is deeply flawed, and we must consider those limitations. And in the absence of head-to-head randomized controlled trials, we have to rely on observational retrospective data. We cannot just throw away an operation that has helped to extend as well as improve quality of life in the right setting. Thank you.
Thank you, Dr. Marie, for an excellent argument. Dr. Matiba, you can start sharing your slides. I just want to ask all the participants if you have any questions to put them in the chat. In the meantime, we can get to them after both parties have sort of given their arguments. Closer to the end, we'll have a rebuttal from each side, and we'll put up a poll so that everyone can vote to see which way they are sort of swinging after the argument. Okay, Dr. Matiba, you can start.
Good morning. Just confirm that you can hear me.
Yeah, and we can see you clearly.
Okay, perfect. Thank you. As mentioned, I'm Marang, and I'll be presenting or arguing the fact that there's no role for cytoreductive nephrectomy in metastatic renal cell carcinoma with the current immunotherapy era. So just a brief overview of my presentation today. We'll briefly just talk about the background of metastatic RCC and how these patients typically present. I think it is quite important to differentiate synchronous versus metachronous metastatic RCC, because a lot of the trials that we have are focused on synchronous metastatic RCC. We briefly touched on the RCC tumor microenvironment, as well as the role of immunotherapy and sort of how we can target these immunological checkpoints. We'll also just briefly touch on the treatment evolution of metastatic RCC, which my colleague has already alluded to. And then we'll just briefly go over sort of the basis of justification for cytoreductive nephrectomy, which is sort of outdated as we speak. And then go into the actual crux of the presentation, which is sort of the evidence against cytoreductive nephrectomy. And then we'll briefly just touch on the different sort of agents and trials that we have currently, and then touch on the guidelines, and then just speak about the future landscape for the treatment of metastatic RCC. So as my colleague already mentioned, there's more than 400,000 new cases of RCC diagnosed worldwide. That's stats as of 2018. And of those cases, 30% have metastatic disease at presentation. And of note, 15% of these patients present with de novo metastatic disease, what's termed synchronous disease. And what's important is that this is usually associated with worse outcomes as well as worse prognostic factors. These patients typically will also present with a small component of these patients will present with sort of adverse prognostic factors like your sarcomatoid component, which becomes important when we sort of argue for or against cytoreductive nephrectomy for these patients. They're usually associated with a shorter time to treatment failure, and a study actually showed that these patients have a poor overall survival of about 28 months versus 49 months in the patients who present with metachronous disease. So essentially who present with non-metastatic disease, and then later develop metastases after surgery to the primary tumor. What we know is that the majority of the patients that present in our setting, especially, typically have a widespread metastatic load. These patients are typically of poor performance status. These patients are typically IMDC intermediate and poor risk patients. And so in these patients, cytoreductive nephrectomy cannot and should not be the primary treatment option. And that's why we are arguing for systemic therapy as sort of the mainstay of treatment. So what we know about the RCC tumor microenvironment, we know that it's highly dynamic and it actually plays a central role in tumor growth, immune evasion, as well as its response to therapy. What we know is that these tumors are quite or highly vascular, and that's owing to the mutation of your VHL gene, which is on your chromosome 3, essentially leading to accumulation of your hypoxia-inducible factors and overproduction of, amongst other things, your vascular endothelial growth factor, which will lead to angiogenesis. And sort of abnormal leaky blood vessels because of your accumulation of your platelet-derived growth factors. We know that these cancers or these tumors are also associated with immune cell infiltration with dysfunction. So we know that these tumors usually have an increased amount of your regulatory T cells, which we know that actually inhibit T cell activity. They also have quite a large number of, although they've got quite a large number of tumor-associated macrophages, dendritic cells, a lot of these are actually functionally suppressed. We also know that these tumors also have high levels of cytokines, like your tumor growth factor beta and your interleukin 10, which we know will promote your T regulatory cells and then subsequently inhibit your T cell activity, leading to apoptosis of your T cells. And we know that your PD-L1 receptors that are on your tumor cells will bind to your PD-1 receptors on sort of your normal cells to prevent T helper cell activation. And we know that these tumors are usually associated with rapid growth as well as abnormal vasculature, and that usually leads to hypoxia, which is further then going to drive angiogenesis. So what we know in terms of targeting immunological checkpoints, we know that inhibitory checkpoint molecules are usually targets for cancer immunotherapy, and that's no different in the setting for RCC. And there are numerous options for investigation. So what we're going to be looking at is your anti-CTLA, which is your anti-cytotoxic T lymphocyte-associated protein 4, which is a protein that's typically expressed on the surface of your T cells. It's an immune checkpoint receptor that essentially works by preventing sort of overactive immune responses. It binds T cells. It inhibits T cells by competitively binding to specific ligands on your antigen-presenting cells or your dendritic cells. And we know that CTLA-4 is actually expressed on your T regulatory cells, which are highly expressed in your renal tumors. We also have your PD-1 inhibitors, and these are typically expressed on sort of your normal T cells. And the drugs of interest here are nivolumab and pembrolizumab. And then in terms of your PD-L1 inhibitors, which are expressed on your tumor cells, these drugs are atezolizumab and avelumab. So my colleague sort of has alluded to how the treatment for metastatic RCC has evolved from the 60s up until the 90s, where we actually saw the first 2 trials. That sort of looked at cytoreductive nephrectomy, but unfortunately, this was sort of in the interferon or the cytokine era. I will briefly talk about those 2 trials in the next slides. These are going to be the SWOG and the EORTC 30947. And sort of where we are now in terms of, my colleague mentioned the third time, the Carmina trial, we've had multiple trials that have essentially evaluated combination of your immunotherapy agents, as well as combination of your immunotherapy, as well as your targeted therapies like your TKIs. And sort of where we're going in the future, as he has already alluded to in terms of the PROBE trial, which will be the first trial that's actually going to look at the role of cytoreductive nephrectomy in the setting of immunotherapy. Okay, so these are the postulated theories behind the survival benefit of cytoreductive nephrectomy. It was initially postulated that cytoreductive nephrectomy actually reduces the level of your pro-inflammatory and your T cell inhibitory cytokines, as well as that, the role of cytoreductive nephrectomy in the sense that it will lead to spontaneous regression of the tumor as well as your metastatic sites, which I'm glad that my colleague actually correctly mentioned that there is no evidence that shows that this actually does lead to a spontaneous regression. They also mentioned that this can also lead to removal of factors underlying your perineoplastic symptoms, your syndromes that are associated with RCC, as well as sort of targeting local symptom control, which will sort of get to the data behind why these are not really relevant in the setting of immunotherapy. Okay, so the first trial that essentially looked at cytoreductive nephrectomy was your SWOG 8949 as well as the EORTC 30947. The clinical question was looking at number one, was immediate cytoreductive nephrectomy safe, and would it actually improve survival outcomes in metastatic RCC when followed by interferon alpha therapy? So it's two different trials. The first trial looked at 246 patients with metastatic RCC. Of note, the majority of these patients were actually good performance status, either ECOG 0 or 1, which we know we don't typically see in clinical practice. And they followed these patients up over a year. And what they found was that the median overall survival was 11 months with cytoreductive nephrectomy versus 8 months with interferon alpha only. Of note, I can just get to the next slide. The reason why we really cannot extrapolate this data to sort of our clinical practice currently is that the major limitation of both these two studies is the fact that it's looking at outdated systemic therapy. Both trials actually used interferon alpha as systemic therapy, which we know is no longer the standard of care, and therefore the external validity to modern practice is very limited. And so the implication, or what I took away from these two trials, is that the benefit of cytoreductive nephrectomy actually may not apply and should not apply in the area of targeted therapies or immune checkpoint inhibitors. The second thing, the second limitation is selection bias. These studies, as I've already mentioned, included patients with good performance status, so ECOG PS0 and PS1, with resectable primary tumors, and actually excluded patients with poor risk, or patients who had high disease burden or quite frail patients. So I think you really cannot generalize this information to sort of the real world and what we see in clinical practice. As I've already mentioned, a lot of the patients that we see are at least IMDC intermediate or poor risk. A lot of these patients have got multiple comorbidities that render them at least a PS2. And so they are not likely to derive any benefit from cytoreductive nephrectomy. The other limitation with this study is that it was quite a small sample size. So 241 patients were randomized in the SWOG study, and then only 85 in the EORTC study. And so I think, yeah, that speaks for itself in the sense that it's really not hardcore evidence that you can really extrapolate and use for our current clinical setting. The other thing is that, yes, although they did find a statistically significant benefit, it was quite a modest survival benefit. Only 3 months in the SWOG trial and only 10 months in the EORTC, with an average of about 5.8 months combined. Okay, so that's essentially evolved, and we got to looking at, cytoreductive nephrectomy as well as targeted molecular therapies. We've got the two big trials that I'll talk about that we're looking at your tyrosine kinase inhibitors, specifically sunitinib, I'll get to those in a bit, and then sort of later in the presentation, we'll touch on other trials that we're looking at, combination therapies of immunotherapy agents as well as your TKIs. We're not going to touch on the mTOR inhibitors, although the studies were there. I think because the evidence that we have currently in terms of we've got good evidence now, as well as the guidelines are actually recommending combination immunotherapy agents. So that's the reason why I did not include that in this presentation. Okay, so now we get to sort of what I think is the biggest landmark trial in this they recruited patients from 2009 to 2017. And the key question here was that they were trying to ascertain whether cytoreductive nephrectomy was actually necessary in the era of targeted therapy. And this was the Carmina trial. It was a phase 3 non-inferiority trial, and the primary endpoint was overall survival. They had secondary endpoints like your objective response rate, clinical benefit, as well as your post-op morbidity and mortality and safety. They enrolled a total of 450 patients that were randomized to cytoreductive nephrectomy, and this was performed 28 days after randomization, followed by sort of adjuvant sunitinib versus sunitinib monotherapy. As I mentioned, the good thing about this trial is that it actually sort of the inclusion criteria was quite broad in the sense that majority of these patients were actually intermediate and poor risk patients, which is what we see in clinical practice. And the median follow-up for these patients was just over 50 months. Sort of the key demographics here to highlight. Unfortunately, 56% of these patients were noted to be ECOG PS0. But what we found is that in the nephrectomy sunitinib group, 55% of patients were classified as MSKCC intermediate risk, and 44% were classified as MSKCC poor risk. However, in the sunitinib group, 58.5% of patients were intermediate risk and 41% were poor risk. And essentially what the results showed is that sunitinib monotherapy was non-inferior to the nephrectomy sunitinib combination group, with a median overall survival with sunitinib alone of 18 months and a median overall survival of the combination group of 13.9 months. So sort of takeaway from this trial is really that there's no survival benefit of upfront nephrectomy. And what we know is that upfront cytoreductive nephrectomy is no longer the standard of care for all patients. And particularly speaking to this cohort of patients that was selected for this trial, it's not the standard of care for IMDC intermediate or poor risk patients as per guidelines. Okay, so the next trial was a CERTAM trial, which was essentially evaluating optimal timing of the cytoreductive nephrectomy. It was comparing delayed cytoreductive nephrectomy with upfront sunitinib versus upfront cytoreductive nephrectomy followed by adjuvant sunitinib. And the objective essentially was to try and see if pre-treatment before planned surgery actually improves outcome by identifying patients with an inherent resistance to your tyrosine kinase inhibitors who are unlikely to benefit from cytoreductive nephrectomy. So they enrolled a total of 99 patients that they then randomized. 50 were allocated to immediate nephrectomy and then adjuvant sunitinib, and 49 were allocated to upfront sunitinib and deferred nephrectomy. What they found was that there was really no significant difference in the 28-week progression-free survival between the two groups. They found that the overall survival was higher in the deferred cytoreductive nephrectomy group compared to the immediate cytoreductive nephrectomy group. But of note, this difference or this overall survival was not statistically significant. What they noted was that in the deferred cytoreductive nephrectomy arm, so these are the patients who received upfront sunitinib, 25% of patients actually had disease progression. And I think the key takeaway from this is that cytoreductive nephrectomy is not always beneficial. And performing cytoreductive nephrectomy upfront actually exposes patients who would have otherwise been non-responders to the surgical risk without the actual benefit. The key takeaway for me as well, especially because of the point that I'm arguing today, is that the surgical complications. So they had a 52% surgical complication rate in the immediate cytoreductive nephrectomy arm, One patient died of cardiac arrest caused by caval vein tumor thrombosis. 2 patients died on day 3 and day 6 post-op, one of an MI and one of a PE. 53% of patients had surgical complications in the deferred cytoreductive nephrectomy arm. And of note, in the restaging 4 weeks post nephrectomy, 20% of patients had confirmed disease progression in the immediate nephrectomy group versus 24% in the deferred cytoreductive nephrectomy arm, which again, as I mentioned, it's not always beneficial. Cytoreductive nephrectomy is not always beneficial, and performing it upfront actually exposes non-responders to the surgical risk without the actual benefit or oncologic benefit. Okay, so the first sort of argument or big argument against cytoreductive nephrectomy is the fact that it is associated with higher morbidity and mortality, as already alluded from the CERTAM trial in terms of how many patients complicated in both the groups due to the surgical risk. We know that there's a very fine balance between the oncological benefit of cytoreductive nephrectomy as well as the potential morbidity of surgery. We know that it's usually associated with significantly worse perioperative outcomes compared to patients with localized cancer. And typically, these patients actually have a decline in performance status post-nephrectomy, in the sense that these patients may not even be eligible for adjuvant immunotherapy, even if they were preoperatively. This analysis in the US actually looked to examine the rates of adverse surgical outcomes in patients undergoing cytoreductive nephrectomy compared to patients undergoing radical nephrectomy in the non-metastatic setting, using a large administrative database in the US from 2011 to 2016. They essentially looked at over 15,000 patients that were included in the study. What's important or pertinent for this presentation is that 8%, so 1,300, were metastatic. And what we know is that 40% of these patients actually had minor complications compared to only 19% in the localized RCC group. 8% had major complications versus 5% in the localized group. As I mentioned, in terms of the minor complications that they needed, 36% of patients needed a blood transfusion. And this is for the patients who had metastatic RCC who underwent cytoreductive nephrectomy. And of those 8% of the major complications that they experienced, they had unplanned reintubation, accounting for 3% of that value, as well as some patients requiring being on the ventilator for more than 48 hours. And of note, 4% of 48 patients actually died within 30 days post-operatively. So what we know is that the perioperative mortality rate between the two groups is statistically significantly higher, with a likelihood of dying within 30 days in patients who are subjected unnecessarily to cytoreductive nephrectomy. Just forgot to mention with the previous analysis, 39% of patients who underwent the cytoreductive nephrectomy required unplanned hospital readmission in the first 30 days. Okay, the second point is the fact that cytoreductive nephrectomy actually delays the start of systemic therapy. What we know is that targeted therapies have actually shown a survival benefit, and that subjecting patients to unnecessary surgery may actually lead to higher mortality rates before they actually receive such therapies. And what we know from the 2 studies that I mentioned, particularly the Carmina trial, which I highlighted at the top here, is that 17% of patients, a total of 40 of the 226 patients who were assigned to undergo cytoreductive nephrectomy, actually did not receive sunitinib. And that's mainly due to the post-operative complications, delayed recovery, and clinical deterioration as a direct consequence of the surgery itself. And then particularly for the argument of upfront cytoreductive nephrectomy, we know that the data from the CERTAM trial that performing cytoreductive nephrectomy upfront exposed patients who would have not responded in any case to the surgical risk without the actual oncologic benefit. And then just to sort of touch on what my colleague mentioned as well, cytoreductive nephrectomy actually has no palliative benefit. He mentioned briefly in terms of, the argument for, in the sense that you can actually use it as a palliative measure for patients who typically present with hematuria or bone or flank pain or any of the perineoplastic syndromes. But what we know from clinical practice is that you wouldn't subject a patient who presents with hematuria straight to upfront cytoreductive nephrectomy. It's actually a tailored approach. It's a stepwise manner in the sense that systemic therapy actually deals with a lot of these symptoms in any case. Secondly, there are other palliative interventions, local palliative interventions that are not as invasive as cytoreductive nephrectomy. And these include things like your renal artery embolization. It's very minimally invasive and it isn't indicated for intractable hematuria. These patients can go for more than one embolization. And what we know with radiation therapy as well, the current trials that have looked at stereotactic body radiation. What we know is that historically or traditionally, RCC is considered to be resistant to conventional low-dose radiation therapy, but the emergence of SBRT actually made it possible to give higher doses of radiation. And this is just a case study that was done in the US that actually just showed a patient who presented with locally advanced RCC that had failed with intractable hematuria, that had failed renal artery embolization. So they gave SBRT over 5 days in 5 fractions, 8 gray per fraction. And 6 weeks post-op, patients actually had improved hematuria with it completely resolving within 3 months post-radiation. And then the other measures like supportive care, what we do clinically in the wards, continuous bladder irrigation in terms of the bone pain, flank pain, giving analgesia and a WHO stepwise approach according to the WHO ladder. So I think to jump to cytoreductive nephrectomy sort of as an indication for palliation, I think that is, that's not good practice of medicine. So we've got, as he's already alluded, there are sort of trials, so different trials on immunotherapy and RCC that look at either the combination of immunotherapy agents or the combination of an immunotherapy agent as well as a targeted therapy. I'll get into a few of those. I'll briefly touch on the Keynote Javelin trials in the next few slides. So the Checkmate 214 trial. What's important is that this was the first phase 3 randomized trial to actually demonstrate clinical activity of immune checkpoint inhibition combination therapy in IMDC intermediate and poor risk patients. The primary endpoints for this trial was objective response rate, progression-free survival, as well as overall survival. So they compared a combination of ipilimumab and nivolumab to sunitinib. And what we know is that the overall response rate was 42% in the combination group versus 27% in the sunitinib monotherapy group. And what they actually also found was that the overall survival, there was an overall survival benefit in the intermediate and poor risk populations, but no real overall survival benefit in the favorable risk population. I think what's also notable, as I've already mentioned, patients who present with synchronous metastatic RCC, these patients, about 15 to 20% of them actually have got a sarcomatoid component in their histology. And what we noted in this trial is that patients with sarcomatoid RCC actually had markedly improved survival with a 55% reduction in risk of death and objective rates of overall or objective response rate of 60% with the immunotherapy combination versus 23% with sunitinib. And then just briefly, this was the Keynote 426 trial, which actually just looked at patients with favorable risk disease. It was comparing pembrolizumab and axitinib versus sunitinib. And what they found was that patients with favorable risk disease actually had better overall response rate with the pembro axitinib combination. And that the overall response rate was 66% versus 49% in the sunitinib monotherapy. What they actually found was the median progression-free survival was also longer with the combination therapy versus the sunitinib monotherapy. And this was the Javelin Renal 101 trial. Essentially, the results are sort of similar. There's the results of the Keynote 426 as well as the results of the Javelin Renal 101 trial are similar in the sense that objective response rates were better and the median progression-free survival was longer for favorable risk patients who in this trial were on the combination of avelumab and axitinib versus sunitinib monotherapy. And I think this trial can actually be used, extrapolated to say that immunotherapy can still be used as standard of care for patients with favorable risk disease, even without cytoreductive nephrectomy. And then this is just a slide on sort of the guidelines, the latest guidelines that we have, in the sense that strong recommendations for offering immune checkpoint inhibition combination therapy for patients with IMDC intermediate or poor risk disease. And what we know is that even in patients who cannot receive or cannot tolerate immune checkpoint inhibition, these patients can still be offered sunitinib, as we know from the previous study of Carmina that showed that sunitinib monotherapy was non-inferior. So what's the future landscape of metastatic RCC? My colleague has already mentioned the 3 different trials that are sort of ongoing, but the biggest one, and I think that will change the landscape of, cytoreductive nephrectomy in the immunotherapy era, is the PROBE trial. Because we actually have not evaluated the role of cytoreductive nephrectomy in the setting of immune checkpoint-based systemic therapy. So this trial actually, the design attempts to answer the question whether cytoreductive nephrectomy actually has an impact on overall survival outcomes in RCC in the context of immune checkpoint-based regimens. So this trial has already started recruiting in 2021 and expected to complete in 2033. And these patients are going to be essentially randomized to 3 different regimens. First regimen will be nivolumab and ipilimumab. And the second regimen would be pembro and exitinib. And the third regimen would be avelumab and exitinib. And then these patients, after about 14 weeks from the start of the trial, will then be randomized to either continue on with immunotherapy or be subjected to cytoreductive nephrectomy, in addition to systemic immunotherapy. And that's it on my presentation.
Thank you, Dr. Matiba, for such a compelling argument. I want to just find out if there are any questions on the floor or any questions in the chat that we can get to. Dr. Marie, you can start sort of sharing your rebuttal slide in the meantime. Any questions? Okay. We'll start sharing a poll in the meantime as well. While our Dr. Marie, you can start with your rebuttal while we are doing that, so that you can vote for who you think made the better argument.
Alrighty. Thanks, Dr. Matiba. That's a really, really nice, insightful talk as well. I think my rebuttal is I'm giving it sort of a less aggressive angle than I think a traditional rebuttal, and sort of want to just touch on 3 things. I think firstly, as I mentioned initially, when we speak about or justify, we're not speaking or arguing if cytoreductive nephrectomy is the be all and end all, but if it is still justified, or it is something, or is it something that is completely obsolete? And I just want to reiterate that it really goes hand in hand with systemic therapy, with the fantastic immune checkpoint inhibitors. It is essentially like a supportive role to in a very select few patients that is fit and healthy and low risk and also respond well, intermediate risk patients that respond well initially to the systemic therapies. Then in sorry, this poll is just in front of my screen. In the setting of justification of a procedure, I think we have to take context into consideration, given our local context, and given sort of speaking about the availability and the cost. And I was chatting to 2 oncologists actually this week and saying that I can't really cost bash the immunotherapies too hard, because it goes hand in hand with cytoreductive nephrectomy, but it is still a reality. I don't know about the different centers around the country in state, but I mean, we do not have immunotherapy to offer all patients or most patients with metastatic disease in my center. So while we are arguing first world medicine, we don't necessarily have that available, and we have to jump back to the previous studies and previous trials, because sometimes that is where we find ourselves. Even in the, I mean, maybe some of our colleagues in private practice have definitely more insight than I have. But just after a short discussion with a oncologist this week, we don't always have all the different immune checkpoint inhibitors available in our country. The cost of it is quite significant. So I had to go work it out. It's obviously based on what sort of maybe a single practice, but the cost of combination therapy, that is, again, we're not really sure how long to give it for, but often it's given for 24 months, works out to about 2.5 million rand. And it sounds like most funds, or most, some, I won't mention names, but some medical aids will cover maybe 50, maybe up to 70% of that cost if you are of the top tier plan. The rest, say an average of 40%, must be out of pocket, which essentially works out to about 2 million rand for 24 months. And if you have to pay it monthly and you have to include your monthly premium, it works out to about 100,000 rand a month for these therapies. And I mean, I think a majority of even patients, privately patients in the country, might struggle to afford this, and that again puts us back into maybe the TKI era or so. So, where I feel we can't just throw out a procedure because we have to consider the context of South Africa, that we don't always have these immunotherapies available. And then lastly, and pretty interestingly, that this is maybe immunotherapy and beyond, where we look at something called the neovax, or where essentially the neoantigen from the renal cell carcinoma gets essentially harvested. The RNA gets sequenced, a vaccine essentially gets produced, and that gets injected back for an extra immunological boost against this tumor. And this is extremely early stuff. This is phase 1, phase 2 trials that's being rolled out now. But because, and just a little bit of reading, because the heterogeneity of both the biological aspect as well as the immunological aspect of a renal cell carcinoma, and obviously in a metastatic setting, just a small sample of the tissue might not be sufficient to have an accurate enough sequence of the RNA. And that might actually be a sort of an immunotherapy and beyond role for a cytoreductive nephrectomy, to essentially it's not just about the therapeutic aspect, but sort of sampling tissue in order to create this new antigen, which is definitely the next generation of a weapon that we're going to have against cancers, and not just renal cell carcinoma. I think it's mostly studied in melanoma and glioblastoma. But yeah, that's all from my side.
Thank you so much for that, Dr. Matiba. Your last few words.
Yeah, thanks for that, Dr. Murray. I just wanted to reiterate that standard of care is standard of care despite the cost. And I think sort of as we are moving, as the landscape of metastatic RCC is sort of changing, as we start to adopt sort of the use of immunotherapy, that cost will come down. But I just don't want us to, compromise on standard of care and good quality of care just because of cost.
Thank you for that, Dr. Matiba. Thank you both speakers for such amazing talks. If we look at the poll, looks like it was a close call initially, but it looks like the majority is in favor of cytoreductive nephrectomy. So thank you, Dr. Marie, and congratulations on winning the debate. From my side, I just want to thank both speakers for such excellent talks, and it looks like it's quite exciting to see what these new sort of studies have to show in this immunotherapy sort of era. I'd like to thank everyone for joining us this morning, and we look forward to the next talk next week, Friday. Thank you.
Thank you very much.